Topic of the lecture today is diseases of the pleura. First of all, we have to know what the pleura is. Pleura is actually a single cell lining of mesothelium. A single cell lining of mesothelium along with connective tissue makes a pleura. That's what its anatomy is. That's what it's made up of. You have to know that a single cell layer of mesothelium and connective tissue makes up for pleura. So we have to know there are two layers of pleura actually. We have to know that what are we talking about when we say pleural space. Actually, these are two membranes. Pleura is further divided into two membranes. One is called visceral pleura, one is called parietal pleura. Visceral pleura. What do you think visceral pleura will be covering? Even the name gives it away. Visceral pleura is wrapped around the lung and it's adherent to the lung. It's not going away, it's not moving away. And on the other side, parietal pleura, it's on a distance from visceral pleura. There's a space between them, and this covers the parietal area, the parietal layer. That's why it's called parietal layer. It's in contact with the rest of the structures. In between them, there's space called pleural space, and in this space, there's very minute amount of fluid present, which is 0.018, I guess, ml per kg of a person. That fluid is present. That fluid provides it with cushion. When we expand our lungs, when we restrict our lungs, there will be a cushion present between these two membranes so that these membranes won't rub off each other. That's why it's present here. So these are called pleural membranes. And then we have pleural space. We talked about this pleural space that provides the fluid, which provides the work for a cushion. So these are called pleural membranes, and we're going to talk about the diseases that are going to affect these pleural membranes. So let's start. First and foremost, pneumothorax. We all of us must have heard of pneumothorax one way or another. What does pneumothorax mean? A quick question. What is pneumothorax? 90% of the people say, I haven't studied it. But the word is giving it away. Pneumo means air. Thorax means thorax. Air in the thorax is called pneumothorax. What are the ways that air can get into thorax? We're going to talk about them. That's what pneumothorax is. As you can see, this is a lung. These are the pleural membranes which are present here. But in this condition, air is present inside the lung, which is pushing it away, which is not letting it inflate. So the lung is collapsed. That's what happens in pneumothorax. This is a normal lung. This is a collapsed lung. So in pneumothorax, on the side of pneumothorax, the lung will be collapsed. There are different kinds of pneumothorax. We're going to talk about them later. All of them have different kind of approaches toward the lung. All of them have different kinds of outcome out of the lung. So let's talk about it. What will be if a patient just had pneumothorax, what will be the key symptoms that he will be coming to you? He just had a collapsed lung. He just had this pathology. What are the symptoms that he is going to present to you with? First of all, the patient will present to you with shortness of breath. Why do you think he is presenting to you with shortness of breath? Because the patient is unable to inflate one lung. So all the bloody vasculature present on this side is not getting the oxygen, is not getting enough oxygen. Body wants to comprehend, body wants to evolve, body wants to give the blood all the air it needs, all the oxygen it needs, but it's not been able to perform that action. The patient will be short of breath. The patient will take more and more breath, but patient won't be able to comprehend for that loss. So patient will present to you with shortness of breath. That's the first sign you look for. Next, patient will have sharp pain while inhaling. Why do you think he's having sharp pain while inhaling? Because when you're inhaling, you're actually inflating your lung. When you're inflating your lung, you're pushing the lung against that air which is present inside the thorax. And it's affecting those pleural membranes. It's hurting those pleural membranes. It's it's affecting that area at which that sharp object got in, or because of any other reason that pleural cavity opened and all the air rushed in, that area will be affected the most. So there will be a sharp pain. That sharp pain will in some cases mostly localized, that in here I have this pain because the patient had trauma right here. So the patient will be short of breath. Patient is unable to comprehend for the loss of oxygen, for the loss of that lung space, and the body is reacting to it. And the patient will have sharp pain while inhaling. The patient will have blue discoloration of lip. Why do you think blue discoloration of lips is happening here? Blue discoloration of lips is happening because one whole lung is collapsed. All the vasculature present on this side of the lung is not getting oxygen. All the blood on this side of the lung is getting oxygen. Both of these are going to go into the right atrium. 100% of the blood which got off to this lung has oxygen. Very less amount of blood which came into this lung got oxygen. So they'll mix together. Oxygen saturation level will go down. So your nails or your peripheral areas, your nails, your lips, will be discolored. They're carrying deoxygenated blood. They are not carrying that optimum level of oxygen to even look red, to even look reddish. So there will be blue discoloration of lips, blue discoloration of nails. All the proximal areas will be okay, but all the distal areas will be blue in color. Increased heart rate. Now heart is responding to all of this. Heart is pumping the blood with more speed so that the blood will go back and get the chance to oxygenate it again, but it's not happening. Next on, pressure on the chest. Patient will feel like 1 ton of weight has been put on his chest because air is inside your chest. Air is putting pressure on your lungs. Air is putting pressure on your chest from inside. So the patient will be feeling pressure in the chest. And then we have loss of consciousness and confusion. In this sharp pain, in this shortness of breath, in this increased heart rate and pressure, patient will lose the consciousness. It will be too overwhelming for that patient. And patient might be confused. Even brain is not getting enough oxygen, so patient might be confused. What will you see on a radiological slide if the patient is suffering from pneumothorax? This is what it looks like. This is what it looks like. See, the lungs are collapsed. The lung is collapsed right here. You can see it in this one too. You can see the whole lung here, whole vasculature here, but you can see this. Air is present here. Whenever you see blackness, it's air. You see, this is outside your body, black, because outside your body what's present? Air. So air got into it, so it's black. So this is what pneumothorax looks like on a radiological slide. Utter blackness present inside your chest, that's pneumothorax. As you can see, in traumatic pneumothorax, if a patient has blunt trauma, if the patient was attacked with a knife, if whatever the reason was, after a blunt trauma, the affected area will be collapsed. So penetrating wound of the chest wall, any kind of penetrating wound of the chest wall will cause traumatic pneumothorax. So it can be iatrogenic, it can be thoracentesis, it can be pleural or lung biopsy, it can be transbronchial biopsy, it can be positive pressure assisted ventilation. So these are actually the causes. All of them are causes of traumatic pneumothorax. Maybe someone put a knife to your chest. You got penetrating wound of the chest wall. Maybe it's iatrogenic. You don't know the cause of it. But are the basic reasons for iatrogenic even? We even know when will we call it iatrogenic. Iatrogenic is called if a patient was already suffering from a secondary pathology. if a patient was already suffering from alveolar destruction, that may be iatrogenic. Then thoracocentesis is a process actually. In that process, pneumothorax can happen because rupture can happen in that. Pleural or lung biopsy. Maybe you're going for lung biopsy. Maybe the patient is suffering from lung cancer. Maybe the patient is suffering from pleural malignancies. And we went into it for biopsies, but we penetrated the wrong part. We penetrated the pleura, and now the patient is suffering from pneumothorax. Now the patient is having that sharp pain right here, right there. Air will rush in. Patient will feel pressure. Patient will feel dizzy. Patient will go unconscious. All of that will be happening. Transbronchial biopsies also have the chance of getting to this stage. Positive pressure assisted ventilation. Which devices are these? These are used in ICU and stuff like that, or places like that. Positive pressure assisted ventilation, they can sometimes cause the rupture. The pressure is too much, too overwhelming, that it may cause a rupture and cause pneumothorax. What are the types of pneumothorax? We're going to talk about the types of pneumothorax. First of all, we have closed pneumothorax. What do you mean by closed pneumothorax? Closed pneumothorax mean that pleural space or whatever it was through which the air rushed in is now closed. It was for a very minute, for a very spontaneous time that it opened, air rushed in, but it's closed now. That's why it's called closed pneumothorax. That area is sealed now. Amount of air entering pleural cavity does not increase. The air that was supposed to come in just came in, and it's not leaving, but no more air is coming in. That's what we have to be thankful about, that no more air is coming in. Thank God. So next on we have open pneumothorax. Air circulates freely. That area which got punctured, that area which was affected, that area which was exposed to the air outside, now that area is there. It's not being closed like closed pneumothorax. It's not being closed. The amount of air which was same in this closed pneumothorax is not happening here. Air circulates freely. Air is coming in, air is going out. Air is coming in, air is going out. But most of the cases, air is coming in. And then comes tension pneumothorax, in which air accumulates in pleural cavity. Air is coming in, but not going out. It has started accumulating in the pleural cavity. That's what tension pneumothorax is. Now, these are the differences of pneumothoraxes on the basis of their structure, on the basis of anatomy, on the basis of what's happening. Let's talk about their differences on the basis of their physiology. In closed pneumothorax, the pressure here is not more than atmospheric pressure. In open pneumothorax, the pressure here is equal to atmospheric pressure. That's why air is circulating freely. It's not compressing it more and more. So it's equal to atmospheric pressure. But in tension pneumothorax, the pressure here is more than atmospheric pressure, and it's pushing it in, and lung is collapsing, and it's over. So this is the physiological difference between these three types of pneumothorax. We have to talk about bronchopleural fistula. In some cases, you'll hear that patient got pneumothorax because of bronchopleural fistula. You must know what bronchopleural fistula is. Actually, it happens in those people which are suffering from any kind of malignancy. Which are suffering from any kind of malignancy. That malignancy causes an opening between bronchial level and pleural level. And that's how they communicate. And that's how this fistula is formed. And that's how it contributes to pneumothorax. So you have to know this, that it happens in malignancy. Next on, we're going to talk about the radiological findings in a patient who's suffering from tension pneumothorax. Contralateral mediastinal shift will be seen. Collapsed lung will be seen at the bottom of it or at the top of it. Decreased hemidiaphragm will be seen. You can see this is the diaphragm here. Decreased hemidiaphragm will be seen. These three findings you have to look for in a patient who is suffering from tension pneumothorax. You got a radiograph, it's showing you pneumothorax, but you have to know which kind of pneumothorax it is. Either it's closed pneumothorax, either it's open pneumothorax, either it's tension pneumothorax, and which is the worst of it, which is the emergency, medical emergency. That is tension pneumothorax. So you see an X-ray, you look at an X-ray, and you see these three things happening. It's tension pneumothorax. You immediately have to intervene. Contralateral mediastinal shift, collapsed lung, and depressed hemidiaphragm. These three are the findings that you must be looking for. Next on we have pleural effusion. But before we go on to pleural effusion, let me tell you that there's some types of pneumothorax which are called spontaneous pneumothorax. What is spontaneous pneumothorax? Spontaneous pneumothorax happens in patients which are very thin, which are young, like 15 to 20 ages and young, but they're so thin, they don't have much fat on them. So they're exposed to spontaneous pneumothorax while they're playing. Whenever you have the scenario that guy was playing and suddenly he developed a chest pain, if it goes on the left side, they won't tell you on the left side. They always go for the right side. So you will be like, okay, it's not heart attack. What else can there be? This is something very important you have to know. That a guy, young guy and thin guy, which does not have much fat on him, gets a sharp pain in the chest, it's actually spontaneous pneumothorax. And it's because of bleb. Bleb is actually an air pocket present on visceral pleura. It's present, but sometimes it ruptures. It just ruptures and causes spontaneous pneumothorax. So you have to be aware of it, just so you know if you counter it in any way. Next on we have pleural effusion. What does pleural effusion word means? Pleural effusion is actually a collection of fluid inside the pleura. This fluid can be anything, literally anything. It can be water, it can be blood, it can be fatty fluid, it can be pus, it can be any of the above. Any of the above, when it's accumulated in the pleura, it's called pleural effusion. Effusion is happening inside the pleura. We talked about it. This is the pleural membranes. We talked about visceral membrane. We talked about parietal membrane. So what's happening is, between these two membranes, between the visceral pleura and the parietal pleura, pleural effusion is happening. Blood or water or pus or fatty fluids are being accumulated here, and they are putting actually a pressure on the lungs. Now these layers can't expand. Now the visceral layer can't expand that much. This visceral layer was this close to the parietal layer. Now see the difference. This space was actually supposed to have very minute amount of fluid. I already talked to you about very minute amount of fluid which was supposed to provide that cushion which was needed in this case. Now the amount of fluid is too much that forget the cushion. It doesn't even let it expand. When it doesn't let it expand, lungs are not functioning properly. Lungs are not expanding properly. Lungs are not taking their whole volume which is required for oxygenation of the blood. So you can imagine what will the pathologies be like. If the body is not getting enough oxygen, if the lungs are not expanding enough, the body is not getting enough oxygen. If the body is not getting enough oxygen, what symptoms did we talk about in pneumothorax that will match the symptoms of pleural effusion? Deoxygenated blood, blue discoloration of the lips, and all the distal areas. So all of that will be happening. So next on, we're going to talk about what will it look like on a radiological slide. This is a slide of pleural effusion. Between the pleura, a lot of exudate or transudate is filled here. So we can't even see it. Whenever there's air outside or inside, it's black. Whenever there's water, it's white. Whenever it's fluid, it's white. And you can see it's filled with fluid on this side. That's what a classical radiological finding you look for in a radiological slide of pleural effusion. So let's talk about the pathophysiology of pleural effusion. So before we get into pathophysiology, I want to mention some things that you have to write down. You have to remember in order for you to perform good in your medical exam. So in this pathophysiology, I'm going to tell you what some major reason is, what's the major pathophysiology. And then I'm going to mention some conditions that you have to write down or get onto your book so that you won't get confused in any kind of questions. So let's talk about it. First of all, increased hydrostatic pressure will lead to decreased oncotic pressure inside. Fluid will shift to interstitial spaces, and that will cause effusion. Now that's very simple. You'll say, okay, that's the cause of effusion, that's it. But there are multiple other causes. I'm going to mention some of them causes to you. You have to write them down. First of all, whenever there's increased capillary permeability, patient is going to get pleural effusion. Increased permeability will lead to pleural effusion. Next on, we have if vascular disruption is happening. If vascular disruption is happening in what conditions? Vascular disruption is mainly happens in trauma. Vascular disruption happens in malignancy. In that kind of conditions, vascular permeability is different. Patient, that fluid might leak and that may lead to pleural effusion. In next condition, we can cause increased capillary hydrostatic pressure can cause pleural effusion. Write it down. Increased capillary hydrostatic pressure even can lead to it. Fluid will leak and you know the rest of the process. So increased capillary hydrostatic pressure. Next, the point is decreased lymphatic drainage. Decreased lymphatic drainage will cause pleural effusion. Then next on we have increased peritoneal fluid between migration. If the fluid migration is increased through the diaphragm via lymphatics or structural damage, that will cause pleural effusion. Next on, if movement of fluid is happening from pulmonary edema, if fluid is present in inside of it, and pulmonary edema fluid is moving out into the pleura, that will also cause pleural effusion. Next on, if the patient is suffering from altered permeability of the pleural membranes, when the patient is suffering from altered permeability of pleural membranes, name two conditions: cirrhosis, or if the patient is going through peritoneal dialysis. Patient is going to have altered permeability of different things, and patient is going to have pleural effusion. So we talked about 8 to 9 conditions that are going to cause pleural effusion, and you have to be very vigilant about them, to identify them in a snap. Okay, increased hydrostatic pressure, increased capillary hydrostatic pressure, pleural effusion. Okay, permeability changes, pleural effusion. Okay, pulmonary edema can cause pleural effusion. Yes, the fluid might shift, the fluid might migrate. So all of these conditions you have to memorize. Now we actually classify pleural effusion these days on two bases. You will listen to this word again and again whenever the topic of pleural effusion will come in: transudates and exudates. So we classify them in transudates and exudates. I'll tell you in what diseases and what pathologies it will be transudate and in what pathologies it will be exudate. Right? So in congestive cardiac failure, first of all, let me tell you in which it will be transudative. It will be called transudative. It will be called transudative in CCF It will be called transudative in cirrhosis, liver cirrhosis. It will be called transudative in atelectasis. It will be called transudative in malignancy. It will be called transudative in hypoalbuminemia. Next on, we have nephrotic syndrome. We have mixed edema. All of these will lead to transudative kind of pleural effusion. Last but not the least, the very important one, always the confusing one, it's constrictive pericarditis will also lead to transudative kind of pleural effusion. Then we have exudative kind. Now, exudative kind consists of the pathologies that lead to exudative kind of pleural effusion. They are pulmonary embolism, malignancies, but those malignancies like lymphomas, leukemias, those malignancy. Pancreatitis leads to exudative kind of pleural effusion. So you have to know why pleural effusion is caused. I told you like 9 to 10 reasons. Then you have to know what's the classification of them on the basis of transudative and exudative. How do you know that if a patient is suffering from CCF, what kind of pulmonary effusion is going to get transudative? You have to remember these names. So in this slide, we learned about all the causes of pleural effusion, their classification, but the basic concept is this: increase hydrostatic pressure, decrease oncotic pressure, fluid will shift to interstitial spaces and will cause effusion. And this is what effusion will look like. In this slide, in this radiological film, you will see pleural effusion. You'll say, what kind of pleural effusion is this? This is actually water. Whenever you hear the word hydro, it means water. Thorax and mean thorax, water in the thorax. So this is what the film will look like. I told you, whenever there's fluid, whenever there's water, whenever any kind of fluid, the film will look white. Whenever there's any kind of air, the film will look black. So this is the film of hydrothorax. Next on, we have pyothorax. What does pyothorax mean? Pyothorax means pus in the thorax. When will pus be accumulating in the thorax? When there's severe bacterial infection, when there's severe kind of infection going on anywhere around it, patient is going to have pyothorax. What it will look like? It will look like this. Whole area is gone. You cannot see it because this fluid is built up and filled up to this level. A little minute area can be seen here. So this is called pyothorax. Next one, we have empyema. Empyema is formed when patient is suffering from severe kind of infection and it leads to empyema one way or another. And in some cases, even penetrating wounds can lead to empyema. So in empyema, if this is the left lung, we suppose this is the left lung, and there was the empyema, and we drained the empyema here, and skin flap is attached to the base of the empyema cavity so that it won't grow back. This will be the diaphragm, and this will be the skin flap. So empyema will be looking just like that, but it won't take all of the area. It won't take, let me show you, it won't take all of the area. It will take just like this area or this area. So it's drained, and this is how the flip is applied here so that it won't grow back. This is what the lung will look like if we see it on a cross section for a patient who's suffering from empyema. Now, look at this and look at this now. You can see I told you it won't contain the whole area, but it will affect this area. You can see if we move it, this whole area is actually affected with empyema, and that's why we drain it and we apply that skin flap so that it won't grow back. That skin flap is attached to it so that it won't grow back. No infection will get to it. And when we drain the empyema, we start very high antibiotics so that it won't just grow back, because if it does, it's very complicated to do that again and again. Next one is hemothorax. What does hemothorax means? Blood in the thorax. For example, a penetrating wound happened. Okay, it didn't rupture the pleura somehow, but the blood is pulling in, and all of those things that we talked about, even the shift happened. So thorax will be filled with blood. That's why it's called hemothorax. Now the blood won't, go as white as the rest of those things. It has different consistency. So this will look like hemothorax. This is how it looks like. And if you go for a cross section, this is how it looks like. The whole lung is bloody and it's filled with blood around. Then comes chylothorax. What does chylothorax means? Chylothorax means a kind of mixture of fat and stuff. That's what chylothorax means. So it won't be, just anything. It happens because of the blockage of thoracic duct. Whenever the thoracic duct is blocked, chylothorax happens. And this will it look like. You can see this whole area is gone just because of the blockage of thorax. This whole area just vanished. You can see it right here that, okay, there's some viability and visibility here. But it, occupies major area of the lungs. Before we move on to pleuritis, so in pleural effusion, we talked about all the possibilities due to which pleural effusion can happen, all the things which are present inside them pleura to cause the pleural effusion. So we have to first we have to identify the reason, then we have to identify whether it's transudative or exudative, then we have to identify that which of these substances are present inside, and then we have to treat accordingly. Next on we have pleuritis. What is pleuritis? Look at this. So this is pleura, right? Those two layers of pleura covering the lungs. So inflammation of pleura is called pleuritis or infection in them. So this is what it looks like afterwards on a cross section. And this is what it looks like on a pathological slide. All the inflammatory cells and all the areas which were supposed to be supplied by the blood and necrosed areas are there, and you can pretty much identify that these two things look very much different. Clinical features of a patient suffering from pleuritis will come to you with shoulder pain, will come to you with chest pain, will come to you with shortness of breath, will come to you with rapid respiratory rate, and will come to you with blue skin. All of these things are happening because pleuritis is happening at that level. Patient will have shoulder pain. Patient will have chest pain because of the pleuritis. Shortness of breath because lungs cannot expand that much. Rapid respiratory rate, the lungs are trying to make up for the loss, trying to oxygenate the blood. Blue skin because blood is not oxygenated enough. Blood is not there yet. So blue skin or peripheral areas will be fine, but distal areas will be blue, like blue lips or blue fingernails. Let's talk about the tumors of the pleura now. Now we talked about if pleura gets ruptured, what happens. We talked about what if pleura is filled with something, what happens. Now let's talk about if there's tumor inside the pleura, what will happen then. Before we get on to that, we have to know there are two kinds of tumors inside the pleura. First, there are localized solitary fibrous tumors. Next on, we have malignant mesotheliomas. Why it's being called mesothelioma? That's a question you have to answer. What actually is the makeup protein or makeup cell of pleura? Mesothelium. We talked about it. It's a single cell lining of mesothelium with connective tissue. So first of all, let's talk about localized or solitary fibrous tumors. What are going to be the clinical features of it? So before we get on to those clinical features, you have to identify, or you have to know that whatever it's going to be those same things that we are thinking in our mind right now. If pleura is compromised, lungs cannot expand, lungs cannot function properly, lungs cannot do all those things it was supposed to do. So in solitary fibrous tumors, This will be the histological slide of the patient. Patient will come to you with chest pain, severe chest pain, because there are tumors present. Pain is supposed to happen. It's going to affect the nerve ending somehow or another, and it's going to cause the pain. But the other reason of chest pain is lungs cannot expand. Pleura is very sensory. Lungs cannot expand now. It's going to cause chest pain. Shortness of breath. Lungs cannot expand. Blood is not being oxygenated. Patient is going to have shortness of breath even while sitting. Next on, we're going to have cough. Patient is going to develop cough out of it because lungs cannot expand. There's increased chance of bacterial colonization inside the alveolar levels. So patient is going to have cough. Patient is going to have hypoglycemia because we talked about it. When patient is shallow breathing, it's going to cause somehow it's going to affect the metabolic and respiratory alkalosis and acidosis, and that will lead to hypoglycemia. Next on, we will have weight loss. All of this is happening. This will be leading to weight loss. Patient is not breathing enough, cells are not being supplied with the oxygen enough, nourishment is not happening at least. Patient, the whole body is trying to sustain itself. So the patient is going to lose some weight. Hemoptysis will be happening. Tumors are growing and growing and growing, and it's puncturing and it's affecting the lungs at that base level. They're going to enter the lungs somehow or another. They're going to cause more and more bleeding inside the alveolar level and the bronchus level, and the blood is being coughed up outside. So that's all. That's what been leading to the happening of hemoptysis. Then we'll have fever. Obviously, the patient is suffering from this kind of pathology. The patient is going through cancer. The patient is going through hemoptysis, cough. Now comes the time of secondary infections. All the secondary infections, all the opportunistic infections will just come in. The whole immune system of the body is destroyed. Blood is coming out of the lungs. Lungs cannot expand. There's no immune system there to reject us. So all the secondary infection will start happening, and that's going to cause fever in this patient. Patient will have night sweats because of these infections, multiple infections, these tumors, these opportunistic infections. All of these will accumulate, and patient will even have night sweats. So in the case of localized fibrous tumors, patient is going to have chest pain, shortness of breath, cough, hypoglycemia, weight loss, hemoptysis, fever, and night sweats. So all of these pathologies will be happening, and you will go for the slide and you'll see this, and then you'll go for localized fibrous tumors. On a pathological slide, localized or solitary fibrous tumor, as you can see, will look like this. And on pathological side, you won't see that much of metastatic cells present. They will be like abnormal cells present, but not proliferating, not getting too much of blood or not getting too much nourishment. Then come malignant mesotheliomas. Those type of tumors which are actually proliferating at such higher speed that it's going to affect the whole lungs, it's going to affect the whole body, it's going to affect the liver even, it's going to get into the bloodstream, it's going to destroy the whole system, destroy all of the systems, affect major systems, and cause the death of the patient. So what you're going to have is pleural effusion. Okay, you have malignant mesothelioma, pleural membranes are disrupted, fluid will rush in, you will have pleural effusion. You will have chest pain because you are having pleural effusion. Your pleura is being distorted, abrupted. You'll have weight loss. Obviously, you're going through a cancer which is eating away your cells, which is destroying your whole body. You're going to lose weight. You're going to have malaise because a lot is happening. Then bleeding will be happening. Then infections will be happening. Then the patient will be suffering from malaise. The patient will be tired. He won't be able to do anything because there's not much nourishment present inside the body. There's not much positiveness present or floating inside the body. On a pathological slide, this is what malignant mesotheliomas look like. You can see the whole, the distance between those layers is totally filled, and it has affected the major part of the lungs. You can see the bleeding here. You can see the bleeding here. So yeah, malignant mesotheliomas look like this. They affect the lungs in such a bad manner that the lung doesn't look like a lung afterwards. This is what the pathological slide of malignant mesotheliomas look like. Look at the hypercellularity, and you can actually differentiate between solitary and malignant mesotheliomas very easily on a pathological slide. So in this lecture, we talked about all the pathologies of pleura. We talked about what actually pleura is. We talked about pleura actually is actually a line of cells of mesothelium, which is supported by connective tissue. That's what pleura is. We talked about the basic pathologies of pleura. We talked about two basic pathologies of pleura, which were first pneumothorax, which is the most common occurrence around us. Any kind of penetrating wound, and the person goes on crying and holds a hand on the chest because the patient is suffering with pneumothorax. Air gets inside the chest. We talked about its type, but it's closed pneumothorax. We talked about there's no communication in closed pneumothorax. We talked about in open pneumothorax, connection is there, but it's not pushing the lung. Then we talked about in tension pneumothorax, the connection is there and it's pushing the lung and it's going to collapse the lung and it's an emergency. You have to deal with it as soon as possible. Then we talked about pleural effusion. We talked about what is pleural effusion, how does it happen. I told you all those 10 possibilities, all those 10 pathologies in which pleural effusion is going to happen. We talked about how those 10 conditions cause pleural effusion. We talked about oncotic and hydrostatic pressure. The difference between them is going to cause it. We talked about transudative and exudative kind of pleural effusion. What are the transudative type of pleural effusion? What are the exudative type of pleural effusion? One thing in that whole thing, the concept we have to get out of that is all of the malignancies like lymphomas, leukemias will be in exudative way. And pulmonary embolism will be in exudative way. But in transudative, we have all of the other pathologies like cirrhosis and like minor pathologies which are somehow dealing with it. Then next on, we talked about what tumors stand for in mesotheliomas and in solitary confinements. We talked about what are fibrous, solitary, benign tumors, how the patient is going to present to us. Then we talked about how a patient who is suffering from a mesothelioma, which is a malignant tumor of parietal layer, of parietal epithelium or visceral epithelium of pleura, how is that patient going to present to us, and how we look and differentiate them on a pathological slide. Thank you for watching sqadia.com.